Welcome back to the Fertility Village Live. We are so excited for tonight's episode as we have a very special guest joining us. If you're looking to optimize your fertility, you won't want to miss this discussion. This month, we're discussing eggs, embryos, and endometriosis.
That's right. And we have Tiff joining us tonight. Thanks so much, Tiff. So we're so excited to welcome Dr. Aimee tonight, also known as the Egg Whisperer. She has a Doctor of Medicine, a Master's in Public Health Management and Policy, and has completed residencies in obstetrics and gynecology and reproductive endocrinology and infertility. Dr. Aimee has become well known for her innovative approach to fertility care that begins with diagnosis before treatment. And she's a renowned fertility specialist here to talk about egg health, fertility. And so Dr. Aimee, thank you for joining us today.
I'm so excited to be here. Thank you for inviting me.
Dr. Aimee, can you discuss with us how you got into this line of work and what makes you so passionate about eggs?
I think there's a gene. It's probably like the FERT1 gene or the really excited about helping everyone get pregnant gene that I inherited from my dad. And then he got it from his grandfather and it got passed down to me. So this office that I'm sitting in right now, literally these walls is the same walls my father worked in for 40 years. And I started working for my dad when I was 12 years old. My dad worked for my grandfather and I got to practice my grandfather. He owned a hospital. So it's just part of my DNA. And this is a true story. My grandfather gave her mother Clomid to have her. My father delivered her from her mother. And then I helped her have a baby. Her daughter, I think, is now like 13 or 14 years old. So it's just in my blood. Yeah. I mean, this is I know it's not like rainbows and puppy dogs and like fairy tales and everyone thinks who's not doesn't have any idea what it's like to struggle, that this is really such an easy job and everything's really happy, but it's not. The struggle is real, but I just feel like I was genetically engineered to help people through really hard things. And I love being a part of people's lives. I love opening my inbox and seeing pictures of families that I've helped over the years. You should see my holiday card box. I mean, in the beginning, it was 3 cards, and now it's it fills a box, and I just feel so blessed. So that's how I got into it.
That's amazing.
I love that. Well, let's start with the basics. Can you give us the 101 and what determines egg health and why is it so important for fertility?
Yeah, I mean, I have mnemonics for everything. So if you don't know that about me, there's a mnemonic for every single thing when it comes to fertility that I've created just to make things easy to understand and learn. And when it comes to egg health and fertility, it's actually age. It's the word age, and that stands for age, genetics, and environment. So I think that is what determines our egg health. So it's the age that you're at, it's the genes that you were born with, and then it's the environment that you've surrounded your eggs. I don't know what the right word is, but the environment that your eggs have been surrounded in, whether it's an environment of nicotine or high pollution or lots of plastics. I mean, that environment makes a big difference.
That's interesting. So we often hear about the significance of both egg quality and quantity in fertility, and how do these factors impact a person's ability to conceive? And additionally, in my case, I have consistently retrieved immature eggs despite undergoing 2 IVF cycles with different medications. I did the Recaville trial and then a regular with traditional medications. We double triggered, follicles looked great. And again, all immature eggs. And I was about 28 when I did my first round. So what steps would you recommend in situations like this or people with egg issues?
The first thing is to rule out silent endometriosis. The second thing is to rule out a genetic cause, like a chromosomal issue that would cause embryos not to grow. I would also rule out and treat any possible hormonal imbalance like PCOS. And then if I had my way, everyone would get whole genome sequencing or, look at all the genes, including the fertility genes, because they're genes that are responsible for how our eggs mature, that if you knew before you started your journey that you carried one of these rare variants, well, they're not so rare, but they're uncommon, that you would have a different expectation going into treatment. You would kind of have the why ahead of time. So some of those genes that affect egg maturity also impact how an embryo grows. So even if you have a mature egg, there's a lower likelihood that embryo will turn into a blastocyst. And then believe it or not, some of those variants also affect how an embryo implants. So I tell patients the answer is often in our DNA. It's in our genes. but we just don't have the test that I can show you that tells us that. There was a company called Cellmatics back in the day. This was maybe like 8 years ago. And they actually had a test called Fertilome, fertility genome. And I thought it was a beautiful test. I did it on all my patients because I was like, wouldn't that be so great? I could actually tell a patient's fortune before she started her fertility journey and just kind of look into her DNA and be like, this is what you might want to watch out for, especially the egg freezers when they're freezing their eggs at like 25, thinking at 46 they can come back and poof, have a healthy embryo, to only find out that it just does not work that way.
Right.
But I think a lot of it is in our genes.
Yeah, one of the doctors did mention to me the TUB8 gene specifically. And so I know in Canada, to get a lot of that stuff tested, we have to send things to Germany in order to get that testing done in Canada.
I mean, you can do it in the US. It's very easy. It's Fulgent is the name of the company. So they have a male infertility NGS or next gen sequencing panel. They also have a female panel, and TUB8 is one of them. I think there's about 83 genes or so on that panel. It's around $800, and the results take about 3 weeks to come back. But it's just not something that everyone like needs to do up front. But I feel like if it was something that everyone could do up front, it might save patients from a lot of heartache.
And who can order that test? Sorry to go off script there. So who can order that test? Does it have to be fertility?
No, anyone can order that test. I actually think there even could be a consumer direct way of getting it done without needing a doctor's order. I'm not sure about that. You'd have to double check that. Okay. But I can order it for anybody who wants the test easily.
Oh, that is amazing. That's super interesting. Well, now that we know the basics, let's talk a little bit about the practical steps. What lifestyle changes can people make to improve the quality of their eggs?
Yeah, I mean, I think the first thing I talk about is like, can you run a 10-minute mile? So I know you're like, what are you talking about running? We're talking about quality of eggs. But lifestyle wise, like if you want your eggs to be in shape, you need to be in shape. I want you to be physically fit. And that also means cardiovascular fitness. That means I want you to do strength training, stretching, and I want you to be able to run a 10-minute mile effortlessly without feel like you're going to die. So that's one. I want you to be fit, because if you're fit, then there's a higher chance that your eggs will be fit. So that's one lifestyle change. The other one is eating healthy, sleeping well, hydrating well, decreasing stress, making sure your relationship with yourself and your partner, if you're partnered, is a healthy one. If you're stressed out, your eggs might be stressed out. If you're not happy, your eggs might not be happy. I know that sounds silly, but that's really what I believe. So I feel like when patients treat themselves kindly and love themselves, then maybe their eggs will be lovelier. And I learned this from Lauren. I think he's the reason why I'm here, because he introduced you to me, but he taught me this kiss your ovary. I'm not sure if you've seen him do that.
No.
So I tell patients to kiss their ovaries and show them love. Is that really going to improve egg quality? I'm not sure, but it can't hurt. So I tell the partners, kiss your wife or kiss her ovaries, whether you do it with your fingers or directly. I can do it with my fingers. It would be weird if I'm kissing my patient's ovaries. Slightly odd. I might get arrested. Yeah. And then obviously environmental toxins like excessive alcohol, smoking, marijuana, just say no to drugs is what I tell my patients.
You mentioned diet a little bit there, but are there specific foods or nutrients that you recommend for egg health? I know some doctors recommend the Mediterranean and some doctors say keto. And I know there's lots of different recommendations out there.
Yeah, my recommendation is anti-inflammatory diet. So foods that are high in antioxidants, fruits and vegetables, avoid foods that are ultra processed, avoid the sodas, avoid the snacks that come in those aluminum lined bags. And that's what I tell my patients. And I don't like the elimination diets. I don't like patients to avoid dairy, avoid gluten. I think that's really difficult to follow, and that can be very restrictive, and it just takes away patients' joy, and they become obsessive over what they eat because it's very difficult to eat that way. So just basically a well-balanced, healthy diet is the best fertility diet, one that you can follow.
We have a question here from Instagram, and it says, hi, I'm just wondering, we're trying to have a successful pregnancy. I have had 2 miscarriages and 2 unsuccessful implants. Do you have any advice for recurring fibroids or to help treat scar tissue post-fibroid removal surgery to help the uterine cavity have a successful implant?
Okay, well, first of all, I'm really sorry that you've experienced 2 transfers that didn't work. That's really heartbreaking. Fibroids are difficult. I mean, if they keep growing into your cavity, you have to keep chasing after them. Of course, you don't want my answer to be get a surrogate or find someone to carry the pregnancy for you. But depending on how many embryos you have and how hard you work to get them, that might be something to consider if your uterus just can't handle a pregnancy. But for recurring fibroids, that's one thing. I mean, we have medications that you can take, like Depo-Lupron or Orlissa. You could take that for 2 to 3 months to really shrink the fibroids down, and that will give you a higher chance of having them grow into the cavity. Then as far as scarring, that's a different scenario. So if you're having the fibroids removed and you're developing scar tissue, the things that you can do include hyperbaric oxygen therapy after hysteroscopy to grow the healthy lining, supplements like L-arginine and vitamin E to also help grow a lining that might improve blood flow, aspirin daily. The other thing that I offer patients is uterine PRP, as well as red light therapy. I also add things like HGH, or human derived growth hormone, to help with uterine receptivity and might help thicken the lining. And then the other thing I have patients consider who've had an issue with implantation, not necessarily because of fibroids or scar tissue, but I sometimes add a medication called Neupogen to the picture, and they take that starting the day of their transfer. So these are some of the things that I think about when it comes to fibroids, is fixing them medically, surgically, and then like you shared, if you have an issue with scar tissue, that's a whole nother challenge and something that you have to really think about when it comes to transferring. So I always say, if you have any doubt, don't. That means don't transfer if you don't feel like your uterus is just as strong as a surrogate's uterus. You really don't want to experience a failed transfer again. Having a transfer rescheduled, that's what I call it. We're just going to reschedule it. We're going to use this as a learning experience. A canceled transfer is really we can get through that. We can get through anything, but a transfer that does not work feels a lot worse having your doctor say, we're going to reschedule your transfer. So I always say, just take your time, be patient. And of course you are, but you have to remind yourself, just think about this process as a learning experience and make sure you get to transfer when your lining is great. And for me, that's at least 8. I just made that up right now. I hope it's like that.
Yes, that was good. Yeah, we've experienced quite a few implantation failures as well. So I can definitely understand where this viewer is coming from, because it's very heartbreaking. One of the other questions that was just asked was, what about the best supplements for trying to conceive? Do you have specific companies that you recommend or a brand that you really like?
As far as supplements, just a good prenatal. Make sure your prenatal has choline in it, CHOLINE. Make sure you're getting enough vitamin D and their omega-3s and fish oil in your prenatal. Or if it's not there, take it separately. I tell all my patients to take CoQ10, and then I also tell them to take NAD, and the brand is True Niagen. If a patient has a propensity toward prediabetes, or maybe they had gestational diabetes in the past, I have them add Ovasitol. So that might help prevent gestational diabetes. But that's just in general what I recommend to my patients. A good prenatal, CoQ10, and then True Niagen, and then Ovasitol if they might have PCOS or prediabetes.
And is that for all of your patients throughout all of their cycles? So patients who
All
are
of
going
them.
through? Okay.
Yes.
Yeah.
Absolutely. All of them. I think that taking these supplements even long term can potentially slow the age-related decline of our egg quality that we see. So my theory is women who saw me, let's say in their 20s, to freeze their eggs, I told them to all call me when they're 40 and reach out to me and be like, hey, Aimee, this is what happened to me. You were right. I actually never had a miscarriage and I could have a baby at 40, just like you said, because I took CoQ10 for the last, 25 years. So that's my theory. We'll see if it's going to be, come true, but that's what I hope that these kinds of supplements can do for our patients. Try and maintain the health of the mitochondria in the egg cell as the patient gets older.
Can I ask how that works with what CoQ10 would do for those using donor eggs?
Yeah, so CoQ10 for those using donor eggs can help decrease inflammation in the body, and that
Okay.
can help with a healthy implantation. Same with True Niagen. We have mitochondria in all our cells, including our uterus. Women who are using a donor egg are at higher risk for a number of things in pregnancy, and one of them is preeclampsia. So having really healthy mitochondria in the uterus is really important, and True Niagen and can potentially decrease risk of preeclampsia. It's also been shown to potentially decrease risk of birth defects. And when you do chromosome screening of your embryos, you're just looking at the chromosomes. We have no way of knowing if the embryo is going to end up with a birth defect or not. So I encourage my patients to take CoQ10 and True Niagen until their heartbeat ultrasound, which here is around 6.5 weeks of pregnancy.
Okay. Interesting, for sure. Why do you recommend choline, and what does it help with?
Choline helps with a lot of things. It helps with baby's brain health. I think it helps decrease risk of preterm labor. It also decreases risk, I think, of craniofacial birth defects like cleft lip and cleft palate.
Mhm.
So there are a number of things that choline helps with. And I don't think we get enough choline in our diet. And a lot of prenatals actually don't contain it. So you have to check and make sure that they do. I personally don't eat eggs. I just drink my food. I don't have time to actually chew. So unless I'm drinking egg whites, I'm not getting any eggs unless it's in my food that I'm drinking. But yeah, so taking choline separately is important if your prenatal doesn't have it.
So we're going to ask you here if you can tell us about your TUSHY method.
I can.
Perfect.
And true story, when I came out with it, I actually had someone, she's like really concerned about me. And she's like, Dr. Aimee, I just want you to know that when you Google TUSHY, it's all porn that comes up. It's all like XXX. You just put into Google. And I'm like, well, finally I got your attention, because I've been screaming this stuff at the top of my lungs. Like, these are the 5 tests that you do to check someone's fertility. It shouldn't be hard. So I'm like, good, you're paying attention. So it just took XXX porn to basically get people to figure out how to check someone's fertility. So it's tubes, uterus, sperm, hormones, your genetics. That's it. If you're having a hard time getting pregnant, it's one of those reasons or more than one. Either your tubes are blocked, there's something in your uterus like a fibroid or adenomyosis or polyps. The sperm is swimming in circles, or there aren't that many. There's a hormonal imbalance, meaning your AMH could be low, FSH could be high, or you could have, let's say, PCOS, or there's a genetic issue like a chromosomal like a translocation or something like that. So, those are the tests that we do. And if anyone is saying to you it's unexplained, you just tell them, I think you're just not explaining it to me. Because unexplained is you haven't received the explanation, or it's untested. So unexplained is also untested infertility. So everyone has an explanation. And if someone tells you that it's unexplained, what you should ask them are, what are the possible explanations? Because I think the possible explanations are probably the explanation. And if you know what the possibilities are, then you'll know what your treatment plan should be.
Yeah,
I absolutely love that answer, just because in our support groups, we hear that so often, where people are like, oh, I have, and myself included, like, I've unexplained infertility. And that's such a great way to put it and to ask that question to our doctors. So that's awesome. I'm so glad that you mentioned that.
Yeah, I think most unexplained infertility, a lot of it is endometriosis, is due to silent endometriosis and adenomyosis. It's just gone unrecognized.
Yeah, I feel like here we're not tested enough for endometriosis.
Yeah.
And you have to advocate quite a bit to even get that diagnosis and to get the surgery. So
how would you diagnose somebody with silent endometriosis? Like, is laparoscopic what you would suggest, or what are your methods for that?
Yeah. So physical exam, pelvic ultrasound, there are signs and symptoms the patient can also report. And then you can see on ultrasound that they actually have signs of it. But I also send them to an endometriosis expert. We have several in the Bay Area. My office is right outside San Francisco. So I'm so lucky to have access to these fabulous excision surgeons. And then they're really the ones that tell me what's going on and whether they think the patient has it or not. Sometimes I do the Receptiva DX test, which is a gentle biopsy from the lining that tells us if there's a chance a patient has it. And then a lot of patients will have laparoscopy if they choose to. If someone's had implantation issues and has lots of symptoms, they don't want to do surgery, then I say, no problem. We'll just assume it's there, and then we can treat them with suppression medications like Orlissa or Depo-Lupron.
Okay. Yeah, we tried Orlissa before, so that's, I've heard of that one.
We have a question here. A little off topic, but is there a trick that you recommend for PO shots so that it doesn't hurt? Suggestion as like heat afterwards or?
Yeah, you remember I'm all about acronyms. So my acronym for the progesterone and oil shots is HIMS. Okay, but it's not in order, unfortunately. So it's heat, ice, massage, shot, and squats, but not in that order. Okay, so that's what you do. But it goes like this: ice, shot, heat, massage, squat. And I could show you. So I'm just kidding. I won't show you. Those are my tricks. So you ice area first.
I love it.
And then you massage it with heat, and then you do squats.
Okay.
Amazing. I love it. That's great. There's so much information out there about fertility. What are some of the biggest myths that you have heard about egg health?
Oh, that it takes 3 months to improve it. I'm like, no.
I've heard that before.
I'm like, you're in control of your health. And people are like, I'm going to quit my job and it's going to be amazing. I'm going to eat healthy and I'm going to stop eating gluten. I'm going to stop drinking. And I'm like, oh, wouldn't that be cool if that was actually a thing? It's not a thing. I mean, but that's all you can control. So it feels good to feel like you have something to do, but you almost have to just say, I'm going to do that. Like do what's just satisfying to me, but I'm also going to let it go. Yeah. And I'm going to go with the flow and understand that I can only control what I can. At the end of the day, I have no control. All I can do is control how I react to what I'm experiencing. I can control my thoughts and my beliefs and how I react to them emotionally. So I'm not harming myself and allowing the process to destroy my mental and physical health. So that's one of the biggest myths, I think. The other biggest myth is that sperm doesn't matter. Just because he knocked up someone when he was 18, it means that, he's fine and that, ICSI will just fix everything. I think sperm DNA fragmentation and elevated sperm DNA fragmentation can impact how an embryo grows. And I think addressing the guy side is really important. I think another myth is that IVF just works and works for everyone. Mm-hmm. And the other myth is that when you do PGTA, you're screening everything and the embryos are genetically screened and they're not. I called PGTA, which stands for pre-implantation genetic testing for aneuploidy. I call it PGT ambiguous because it's a very unclear test. However, it's very useful. It allows us to prioritize embryos to transfer. It allows us to not choose an embryo that, let's say, has trisomy 13, 16, 18, 22, 21. Like these are embryos that it can actually grow until you deliver and then stop growing soon after birth, which is like so heartbreaking. But I think a lot of embryos are discarded and destroyed and not given a chance unfairly. And patients aren't truly understanding that PGTA is not PGTA accurate. It's PGTA. It should be PGTIA or inaccurate. So I transfer embryos from all over the world from patients who move them here that are abnormal, low mosaic, high mosaic. I give segmentals, chaotics. I give every embryo a chance if a patient wants that chance, because I have seen abnormal embryos turn into healthy babies. So those are some of the biggest myths.
Yeah, I've heard that too, because they're only testing a couple of cells within the embryo. So like they could be abnormal cells, but they could be like normal cells throughout the rest, and then say vice versa. So I've heard some things about that as well. That's interesting. We have a couple other questions coming in. So how does endo affect an FET?
Yeah, so endometriosis is basically inflammation. And if you have inflammation around an embryo, it's less likely to implant. Can you have endometriosis and have a successful implantation? Absolutely. So I don't want you to think that just because you've received that diagnosis, you can't get pregnant naturally or with a transfer. But depending on how severe it is, you might want to talk to your doctor about suppressing it first, using a modified natural cycle transfer, for example, that uses letrozole instead of a controlled cycle, which is pure estrogen that could stimulate even more inflammation. The other thing about endometriosis, I think it can cause inflammation to collect inside the fallopian tubes, and that can also be harmful for an embryo and make it less likely that it successfully implants. So basically endometriosis equals inflammation, which equals potentially a lower implantation rate.
I have a question here, not that it's been asked, but now my personal question. If you were to succeed and that embryo were to implant and you have endometriosis, can that inflammation affect the uterus so much that you could lose that embryo?
Yeah, absolutely. It can increase risk of miscarriage. And if the inflammation from endo is even more significant and you have adenomyosis, it can cause preterm labor and delivery even before viability. And it can also cause postpartum hemorrhage, because if you have inflammation in the walls of the uterus, it makes it hard after delivery for the uterus to contract back down, and a woman could potentially need a blood transfusion after she delivers.
So in the spirit of endometriosis awareness, and because we're kind of already talking about this, can you speak to the impact of endometriosis on egg quality and on embryo quality?
When it comes to endometriosis, it can rob a young woman of her fertility. So my thing is this: if you didn't know that endometriosis is something that you can be born with, you should know. And if you're born with it, you could suffer as a teenager. And sometimes these young women have surgeries that involve removing ovaries before they're offered fertility preservation. So endometriosis can rob us of healthy eggs. Endometriosis can make our eggs run out at a younger age than one would if they didn't have endometriosis. Endometriosis causes eggs to be less mature. It also causes eggs to be less viable. So a woman who has endometriosis could have a lower blast formation rate and could have a lower blast euploid rate. So they might have more abnormal embryos than someone that does not have endometriosis. So I encourage women who have endo to freeze eggs. If, let's say, you're partnered or you're ready to be a single mom by choice and you have that diagnosis of endometriosis, please don't wait. Go ahead and freeze embryos now just to preserve your fertility for the future. You can still try naturally, but you're going to thank your younger self for storing embryos for when you're older, ready for more kids. So those are some of the things that endometriosis can do to a woman's eggs and how it can impact our fertility.
Do you recommend, because you said freezing embryos, do you recommend freezing embryos over freezing eggs? If you can?
Oh yeah. I mean, if you're in a situation where you're freezing your partnered, and yeah, absolutely freeze embryos. I think a lot of times like young women are like, freeze your eggs and save your fertility or preserve it. But married couples or people who are partnered aren't encouraged to do the same thing. It's like, have a baby. Don't have a baby until 2 years after you deliver. And everyone's asked as soon as they have a baby, when are you going to start birth control? Rather than, what's your AMH? Do you have any fertility threatening conditions that we can potentially freeze embryos for? Because that's what I would do if I was delivering babies, which I don't. So yeah, I think more people should know about age-related decline in fertility. One of the most common reasons for secondary infertility is age. So if we educated people about that when they had their first baby and said, like, don't wait 5 years to try. I mean, you can, but if you're going to wait that long to have your second baby, freeze eggs while you still have them or make embryos.
You talked a little bit about the genetic components. And do you see that often running in a family? Like, do you often see like siblings?
It can. Yeah, absolutely. Sometimes within like brothers. But the problem is a lot of people don't talk about this stuff. Like, I'll talk to someone and I'll be like, yeah, my brother doesn't have kids, but we don't talk about it. I'm like, well, talk about it. This is a good time. Let's talk about it. I mean, in my family, we talk about everything. And when I say everything, like you'll turn red when I tell you what we talk about. But a lot of families don't. I mean, no one talks about this kind of stuff, and everyone just about the weather and what they ate for dinner or which restaurant they're going to go to. But it would be good for people to have these deep conversations about their fertility history and what runs in the family. I got to tell you, my first patient in my practice, she was 40 years old. First patient. And I diagnosed her with primary ovarian insufficiency, which is early menopause.
Right.
And I said to her, how old was your mom when she went to menopause? And she goes, I don't know that question. I'm like, how do you not know that question? Her mom was 40. And I was like, if only your mom had told you 10 years ago, then you could have frozen your eggs. And then her mom felt so guilty. She's like, I had no idea that this runs in the family. So it's like, we need to educate people about, if you're dealing with something, tell your family members, tell your kids, tell, your sisters and brothers so that they don't have to suffer the same way. So if there is a genetic component to what you're dealing with, they can be spared a lot of the heartbreak or some of it, or at least have the knowledge and information so they can meet with a doctor sooner than later to help them.
Yeah.
Definitely.
I was just curious because both my sisters had no issues, and my sister's like, we're getting pregnant this month and we're going to get pregnant and we're going to have kids 18 months apart. And like, that was the thing. And my other sister didn't have much difficulty getting pregnant either. And then it came to me, and I was the first one in our like family, and everyone's like looking at me like, we don't understand, why is it not working? Like we're having a kid. When is this happening? So I think I was just curious if you saw like a genetic trend in like families.
I do see a genetic trend, but you can also have a variant that's sporadic and something that just occurred in you without being in the family also. And it could also be something that your dad might have passed on to you, and you can't ask your dad questions about like, what his egg quality is like and stuff like that, because clearly that just wouldn't happen.
Right. And I do know that the TUB8 gene, that's the one specifically someone had mentioned to me, and that does get passed on from your father side of the thing. So maybe this is something that we would look into.
TUB8, GDF9, BMP15. There's also ZP1, 2, and 3. There's so many genes, and they're all listed. If you go to Fulgent Fertility, Infertility Female NGS panel, you'll just see the list right there.
Okay, interesting. We do have another question here, and it says, how old is too late to freeze eggs? I'm 38.
You're never too old to freeze your eggs, ever. If you have an egg, you can freeze it. The oldest egg that I've ever frozen is 51. Not a joke. She was waiting for the right guy. Not joking. So the thing is that I encourage women to be knowledgeable about what the likelihood of their eggs turning into a pregnancy will be before they start their journey. So they're not given or feel like they've been sold some false hope. So at 38, the likelihood of an egg passing genetic screening and being healthy is around 25%. So for a 38-year-old who wants 2 kids, I'd want probably at least 30 eggs frozen for her to give her at least a 50% chance of having that. So that's what I would want if it were me, and that's what I'd want someone to tell me. So that might be doing about 3 to 6 rounds of egg freezing. So can a 38-year-old have a successful pregnancy with frozen eggs? Absolutely. But do you have to freeze a lot of eggs to give you a really good chance? Yeah, you have to freeze more than you would freeze at 28. But the thing is this, like if I tell my egg freezers, look, like if you're potentially going to do this on your own in the next 5 years, you're going to choose the love of a child over the love of a man, then potentially do a round of eggs and then do a round with donor sperm so you can see, how your eggs perform. Then you're going to kind of know like how many more rounds you might need to do to have enough eggs for baby number 2. So those are some of the things that I tell egg freezers, especially women at an age where they're close to the age where they're going to start running out of healthy eggs. I want them to realize that they should be freezing more. A lot of people just freeze and forget. They just do 1 round and then they see me and they're like, I wish someone told me. But now we're here. So no one listening to this can say, I wish someone told you because I told you so.
I think, and I've mentioned it before on a previous live, is that after our first failed round of IVF, I consulted a few different specialists, and one of the specialists, and I feel like he was the most honest doctor I ever met with, said, if people want a couple of kids, I tell them that you typically have to go through at least 1 to 3 rounds of IVF to have a successful, like this amount of kids that you would like. And I think that was the most honest thing that a doctor ever told me, because at a lot of other clinics I'd been to, they're like, oh, you're going to have no problem getting pregnant. Like, we'll put you on the IVF list, but you're not going to need it. Or, you'll go through your IVF. Once we do this cycle, you're going to get you a baby. And I think that was the most honest thing a doctor had ever said to me, was the fact that, like, not everyone gets to do just 1 round of IVF and get potentially have a baby or have all of the kids that you want to have through that one cycle. Right. So I think that's really honest what you were just saying there.
Yeah. Yeah.
So we have lots of questions coming in today. A couple for AMH. What is the best time in your cycle to test for your AMH? And does it drop during your pregnancy?
Anytime. So I call AMH always meandering hormone. And so there really isn't a particular time, or always mean hormone, because it upsets us, especially when it like drops a little bit. And all of a sudden you're like, if you're thinking about that rate of drop and then you're calculating when it's going to be 0, and all of a sudden it's going to be 0 in like 2 months, but that's just not how it works. Very slowly meanders over time. until it goes down to 0. So not cycle day dependent. So there isn't a particular day at all.
And then during
And it
pregnancy,
does, yeah, it does. It is suppressed during pregnancy. I don't know exactly how much it's suppressed, but I would imagine probably around 20%.
What is one thing that you wish people understood about fertility and egg health?
I mean, I think the one thing is like our bodies and our eggs were like biologically designed to have kids when we were 18. So that's like how human beings were designed. And I don't think people understand that about our eggs. And so when someone comes in at 32 and they're like, but I'm so young, I don't understand why I have egg quality issues. And I'm like, well, from a societal standpoint, you're young, but like our ovaries, like our fertility starts to decline, our egg health starts to decline between 25 and 28. Some cultures, like in my culture, in Middle Eastern culture, like if you're like, 30 and not married, you're like an old maid. It's like I didn't get married till I was 32. And my mom was like, do you have a pulse? Like, can you marry my daughter? What are you doing on Sunday? But I think in our culture here in the US, I see patients coming at 42 to 45 ready for their first baby. And I have to explain, the age related decline to them. So I always do it gently and lovingly, but I feel like that's just something that I wish they knew more about when it comes to an egg.
Couple more questions coming in here. Is there anything specific you recommend for a 45-year-old woman with DOR? Can they get better egg quality? Is there any suggestions for the best success or any success? She said, I did IVF and I had one child at 41.
Yeah. So I love just learning about things that could potentially help and trying them. And so the first person I usually try them on is myself. And so what I'm talking about is a drug called rapamycin, also known as sirolimus or Rapamune. It's an anti-aging drug that is approved for preventing organ rejection in transplant patients. So you're like, how is that related to fertility? It is sort of related because the medication is called an mTOR inhibitor, and it prevents fungal infections in the transplant patients. But for women, it might actually slow the depletion of eggs in our ovaries and delay menopause by up to 5 years. It can increase the AMH and give us a higher egg count. What? I know.
Yeah.
So I'm also almost 49. I don't want to tell you my AMH because it might seem like bragging, but my cycles are totally regular. No hot flashes. I'm 28-day cycles, normal FSH, and my AMH is like mind-blowing. So I've been using that now in my patients. The oldest patient that I've helped get pregnant with a healthy pregnancy now is 46. And so that's one thing that might help. The second thing is something that I also specialize in. I have not done it on myself, and that's called ovarian PRP. So that's the injection of platelet-rich plasma into your ovaries.
Have you done that for, seen any success with that with immature eggs? Is that
people
getting immature?
I have. Yes, for patients with immature eggs. Yeah, I have a patient, I think she did 2 rounds, completely immature eggs. And I did ovarian PRP for her, and every single egg almost was mature. Actually, her transfer is coming up in 2 days.
We have another question here. I've had a chemical pregnancy with a PGT eploid and have one more eploid left. If that fails, how many eploids would I realistically need for successful pregnancy? I'll be 37 in July.
Yeah. So the first question is there any inflammation in the uterus? Do you have endometritis? Do you have endometriosis? Have your fallopian tubes been checked? Do you have an autoimmune condition like antiphospholipid antibody syndrome? So that's the first thing I do if someone's had a biochemical. I also look at the quality of your embryo because if the quality was low quality, that could explain why you had a biochemical. Look at the lining of your uterus. Make sure that you were super happy with everything going into this transfer and wouldn't make any changes. So that's the first thing. If you have one more euploid left, ask your doctor what the implantation rate is for that embryo. So have them give you a percentage. And if they say all embryos are the same, it doesn't matter what the quality is as long as they're euploid, you can say, you know what, Dr. Aimee said that that's a lie. And you're lying to me. So just say like, that's cute, but Dr. Aimee said that's a lie. Truly, in your lab, what is the likelihood of this embryo at this quality what is the implantation rate? And if they say it again, you say, then what's the point of even giving the embryos a grade? And if they say it again, you can say, I'd like to talk to your embryologist. Most clinics will allow you to talk to the embryologist, and embryologists won't tell you a lie like that. They'll tell you exactly what the implantation rate is for the embryo, because then you will know how many euploids you need for a successful pregnancy. So if you have 2 lower quality embryos, you might need 4 or 5 to have a successful pregnancy if they're like 10%, implantation rated embryos. If you have, let's say, an AA blastocyst, then that's an 80 to 85% chance. Then you might need maybe 1 to 3. So that's why knowing the quality of your embryos is really important, so that you can make sure that you have enough embryos for the family size that you want before you start your transfer journey. And taking a pause as you're, experiencing something that's really heartbreaking, like a biochemical, to kind of figure this out with your doctor is a good idea.
Do you always recommend testing your embryos? I know that a lot of doctors I have come across say that they don't bother testing because, again, kind of like you said, abnormal embryos can result in healthy pregnancies and if people want to transfer them. So I'm just curious.
Yeah, I offer it to everyone. Not everyone wants to do it. I would say probably 98% of my patients still do testing because they know that they have me. They have someone who's honest and transparent, and I'll share with them what the results mean and whether I would transfer any of the abnormals, and they get a chance to do that with me. So that's why I think that testing can be helpful, because you'll be able to select embryos for transfer. We're not like discarding embryos just based on the abnormality. Sometimes we do. I mean, there are sometimes very clearly embryos that we shouldn't be transferring, but there are some that could actually turn into a healthy baby. So we want to give those a chance.
All right. This has been such an insightful conversation, Dr. Aimee. Where can your listeners find you if they want to learn more?
Any search engine where you can put in Egg Whisperer, you can find me. I'm everywhere. Spotify, YouTube, Instagram, Facebook, Medium, Twitter. I'm everywhere.
And you have your own podcast, I believe, right? The podcast Whisperer
Spotify,
Show.
Egg Whisperer Show. Absolutely.
And then YouTube is another one, right? I think I've seen that one before.
Yep. YouTube too.
Thank you so much for joining us, Dr. Aimee. And to
You're
all of our
welcome.
listeners, thank you for tuning in for this conversation. If you found it helpful, then please share it with your community. We also just want to mention, please don't forget that our tickets for our Oasis Fertility Gala on June 22nd are now on sale. So thank you so much, Dr. Aimee, for being here today and sharing all of that knowledge. You gave us so many good nuggets. I feel like I have to go back and listen to this episode again to write some of them down.
I know. I feel like I have to sign up to be your patient because I'm here's my chart and figure all this out for me.
You're very sweet. Well, thank you for your time. Thanks for inviting me. It was an honor.
Thanks so much.
Thank you.
Yeah, so you guys can find us at oasisfsn.com, at oasisfsn on Instagram, and the Oasis Fertility Podcast on Spotify or YouTube. So remember, you're not alone, and welcome to the village, and we'll see you guys next time. Thanks for joining us, everyone.